right, it looks like we are now streaming live on Facebook, so yay. So sorry about the technical difficulties, but we're here. So we got to get a shout out to Layla, who came on a Saturday as she was coming back from grocery shopping to jump on to get us streaming. So props to Layla. In saying that, I do not have our Facebook page pulled up, so until I cannot see the comments. So we're just going to go ahead and start since we're late. Yes, Miss Eileen?
I can monitor the Facebook page.
All right, so this is Eileen, and she's going to help monitor the Facebook page until Deb and I can figure out how to get on it. So in saying that, we love technology. That is fine. Okay, so in saying that, thank you for tuning in, and we want to welcome you to our official 2023 Go With Us to Conferences program that we have done for a couple years. We'll tell you a little bit about the program and then jump in on the major themes. We are scheduled for around 90 minutes. We understand if you need to pop in and pop out, and this will be recorded, so you can always come back as well. So first, introductions. My name is Tiffany Westridge Robertson. I am the CEO of International Foundation Autoimmune, Autoinflammatory Arthritis. We just say AiArthritis for short. And I am a person living with non-radiographic axial spondyloarthritis and a couple other things that you might see on my chart. But the thing to note is a person living with the disease. So I'm going to turn it over to my long-term partner at conferences, Miss Deb. Hi, Deb.
Hey there, everybody. I am tuning in from the Madison, Wisconsin area. My name is Deb Constein. I was diagnosed with RA, JRA, whatever they called it back in the day, at the age of 13, and I'm having my 40th anniversary now, so I'm old. But again, I am happy to be here. Lots of comorbidities and multi-morbidities. I'll tell you a little bit more about that soon. And yeah, happy to be here as well. Eileen, take it away.
Hello, everyone. My name is Eileen Davidson, or also known as Chronic Eileen on the internet. I am a rheumatoid arthritis patient advocate and writer from Vancouver, BC, Canada. I had the extreme pleasure of attending EULAR 2023 with both Deb and Tiffany with the Go With Us program. It was not my first research conference, as I can now proudly say I have attended the Canadian, American, and European rheumatology conferences in person and online. Thanks to this Go With Us program, actually. And so it's a pleasure to be here and kind of share the knowledge that I have as a research partner and also a volunteer and staff member with AiArthritis.
All righty. So for those of you who are not familiar, we have this program. It's called Go With Us, and that's literally what we strive to do. It is a constantly evolving program. And so your feedback always helps us to build it. Positive feedback is also welcome. So we like hearing the constructive criticism, but we certainly like to hear what we're doing well as well. So this is a project that started about 2 years ago. And obviously when we were in the COVID world, it was hybrid and it was online. So if you've gone with us before, a little bit of a different experience when we were able to watch some of the sessions with you, literally. But now we're back in person, so that's a little bit more difficult to do. And saying that, the way it works is you sign up for free. We at aiarthritis.org/conferences. And then we ask you what level of participation you're interested in. So that could be the minimal level, which is you get an update relatively every day. It usually has some sort of video update that we have done from that day that our admin team back home puts together and sends with some links and some updates. And then you can go really with us and get zapped in to a private WhatsApp group. So I want to give a big shout out. I know there's several of our WhatsApp Go With Us that are tuning in. A couple of them said they were going to set their alarm for like 1 o'clock in the morning. What? So love you guys. Big hearts out to the people who are on the WhatsApp group that have really was with us through the whole thing. And since we got back early June, and that group has still been alive and kicking. And they have helped us sort of narrow down what we're going to talk about today, because there's a whole lot of stuff. And just FYI, make sure you sign up for the Go With Us to Conferences link on that aiarthritis.org/conferences page, because we aren't done. There's still going to be a watch party from some of the highlights of the, now that we have access to the sessions and the videos, we're going to pick some of those clips. That will be in the next 2 to 3 weeks likely. And then we will wrap up the Go With Us to EULAR experience. But even oh no, we will still be reporting back breakout information that we can't quite fit in here or in the watch party throughout the year on our social media, all of the platforms, AiArthritis, and also on a new blog that we're going to put on our website. So there you go. That's the introduction to that. Also, I just wanted to point out a big shout out to Creaky Joints Australia, Vasculitis Foundation, Vasculitis Chile, Axial Spondyloarthritis International Federation, or ASIF, Dragon Claw, and several ambassador volunteers from the US Arthritis Foundation, all who also have been going with us. And we just think that's so super cool that these organizations are saying, you know what, we love what you do and we want to be part of it. So we just think that's amazing and awesome in itself. So big shout out to all of them. Some of them I know who are on the stream right now. All right, anything else that you all, Deb or Eileen, want to say to preface this before we jump in?
Just that it's an honor to be able to do this with everybody. And again, we keep learning and making changes to our approach with the Go With Us, and we are making it bigger and better. We don't stop moving when we're during the conference. We don't stop moving. We are, dividing and conquering and just bringing back all the wonderful nuggets for you guys, so you understand what's happening behind the scenes and what it actually is like going to the conferences. We did a lot of that and shared a lot of that in the WhatsApp group. So please keep giving us more input of what you like, what you don't like, and we'll keep changing and morphing, because that's kind of how we roll here with AiArthritis. We learn, and we also learn what is not attainable, because sometimes we're so tired. That's why we're like, yeah, that's not going to happen.
meaning the daily updates. So
yes,
that happens.
yes.
So to those who went with us to EULAR, there were a couple times where we overestimated our ability as people living with these conditions to go to a conference all day, then go to get home by 7:30 and actually try to record it realistic. So we did learn our lesson there. So
we should also highlight that we were definitely experiencing some jet lag, as it is quite the time difference and it was quite the far trip. I know that I had really bad jet lag pretty much every single day I was there. So you're definitely fighting some disease symptoms while going into these conferences. There's kind of no way around that. You sort of learn to navigate it, go with the flow. That's why I really love these, that we're able to go through the sessions again after, because living with these conditions, we're probably not catching everything.
Right. All righty. So in saying that, we are going to get ready to fully start here. What I'm going to do is I'm going to give you just a quick overview of the major themes that we're going to cover. Then we're going to break out into those themes. We're going to give you what Eileen likes to call the nuggets. So we have adopted that word. So we're going to give you some of the nuggets, that takeaways that we think patients most want to learn. Think about this. These conferences, that most of the sessions, I know the ones for sure, Deb and I had seen some of the ones Eileen saw fell under scientific and then also under what's called RA, and that is the patient organization / patient legs. They actually have a whole track with sessions that are designed for patient organizations and patients. So that's very nice. We don't see that at a lot of the other conferences. But the ones that are not PARE, the audience is rheumatologists and researchers. So that's why we really have to zero in and understand the nuggets, because it's not intended for patient takeaway, right? So that's where we come in and try to break this down. In saying that, I got to also give a shout out to Michael. Hey, Michael, our volunteer management and admin assistant. He is here on a Saturday and offered to get in the chat and help us share links. So big shout out. He's living with psoriatic arthritis, as all of the leaders at our organization are some way affiliated with our diseases. So shout out to him. He's going to be sharing with a lot of links so that we don't have to try to navigate that ourselves. All right, so here we go. The major themes this EULAR were pre-RA, and I want to say, even though we're saying RA or rheumatoid arthritis, that does not mean the information we're sharing is only relevant to rheumatoid arthritis. The reason there's so much research on rheumatoid arthritis, especially when there's early research into another innovative way of doing research, RA is the easiest disease to study for many reasons. It has the most people who tend to be in trials, which is one thing, but it is one of the easier ones. And then it can be applicable to the other diseases. It's easier to build on than starting with like a lupus, for example, which has a lot of complex factors. So keep in mind what we're saying about this is very relevant to the other diseases. We're also going to talk there's a lot of movement towards early disease, prevention, remission, and tapering. This is something that you're going to be able to also, if you want more in-depth research on that topic and this strand itself, you can always go to our YouTube channel, our AiArthritis YouTube channel. Under our playlist, we have all of our past Go With Us to conferences. This has been a theme for, I'd say, 3 years now. So it's really happening. They're really talking about taking us off of treatments if it's a possibility to be in remission, something I never thought I'd see in my lifetime, to be quite honest. So
both of us, we dropped our jaws. We're like, wait, what are they talking
about? Right. So that has evolved. That's going to be one thing we're going to mention. We're going to talk about developed disease, because some of us are way past pre-RA and early disease, or pre-disease and early disease. And that's going to include difficult to treat and comorbidities. The whole report is going to somehow be sprinkled with precision medicine, because there's no way around it. That is the way science is moving forward. Precision medicine is the study of your molecular structure, your blood work, your biomarkers, your genes, your DNA, your RNA. We're even going to talk about artificial intelligence, which made a huge splash at this EULAR. So there's no way around it. All of the studies are moving into targeting treatments for you and me so that we can respond best for our disease, which then could go to remission and tapering, right? All goes together. Eileen is largely going to take us into the non-pharma, which is support, mental health, exercise, and pain therapy. We're going to do a feature on brain and rheumatic diseases and the brain fog, which was Eileen and my favorite session. And we're going to wrap it up with some recommendations. So here we go. First, behind me, this is an actual picture of EULAR. So this is Eileen and I were standing up taking these pictures. So on this side, you're going to see these research abstracts. Okay, so research abstracts are these big posters, and they drive what we see in the sessions. So there's thousands of them back there, and not every one of those makes it to a session or wants to be a session. It needs to be at a certain level, a certain stage of research. So this time we saw a whole lot of exercise, barely anything with diet. That doesn't mean that diet isn't being studied. There's probably some posters back there, but it's just not at the point where they're ready to really present something. So maybe the next time we go, there's going to be all kinds of stuff on diet. We don't know. But that's where it starts. And then this side was the side we weren't allowed to. That was the pharmaceutical booth. So we just looked from above. All right. So let's jump ourselves in here. The first update is we are going to talk about pre-RA, early disease prevention, remission. And I'm going to turn it over to Deb to lead us off, because I've been talking a lot. So Deb, whatever you'd like to talk about in that particular genre.
Yeah, so pre-RA is, so it's been at least a year or two that Tiffany and I have been seeing a lot that's being presented on pre-RA. So people are starting to show some symptoms, and it gets really interesting as far as, I mean, who knew that there would really be a pre-RA? And right now they're trying to make decisions on, do you treat those pre-RA people? Do you not do that? Where do you jump in? So there's lots and lots of discussion as far as how that even started. There was a session that I actually went to. It was called Predictors of Outcomes in Early Rheumatoid Arthritis. There were about 8 different posters, and they were very basic science. So I'm a medically retired dietitian, so understanding that, but right now.
Could you tell them what basic science is?
Yeah, so basic science is just pure like molecules. It's talking about all the amino acids and all the different little technical pieces that rheumatologists and researchers are digging into.
And
so
it's also early. So these are where you hear mouse studies.
Yes.
So if they're talking basic
all
science, we are really early in the process of the study.
So not even human studies in a lot of cases, it's talking about like the mouse and rat and small animals and things like that. So it's very high technical jargon that you're taking in. But at this time, I think a lot of it is very early as far as these studies go, because it's becoming a new theme, and these research studies are now becoming they're digging and gathering the information to where they can take it to humans. So that's how early we are talking with this, but it is definitely getting some traction for sure. And Tiffany and I have been seeing that for a couple of years. Eileen, how about you in Canada? Are you hearing it too, as far as pre-RA?
There has been some talk. I don't know if they were calling it pre-RA, but more I've seen studies about if they can use therapies for people that maybe have genes or hereditary components.
Right. That's exactly pre-RA.
Yes.
So they might not be calling
it's interesting. Like, you won't necessarily hear the same names in some places.
Yes.
So yeah, that's something that's I guess something that could go in the glossary, because I didn't really have a name for that, but yes, I have heard of it before. And I think that it is something that's kind of trending in all of the research communities around the world. So, and as somebody who, has a child, I love that, because it's my biggest fear, my son ending up with this condition.
Me too.
And I'm sure that Deb also has the same concerns.
Yes, and just to reference a little bit more of the science part as well. So there was specifically this talking about what Eileen said with genes. So we're really seeing a lot of this precision medicine biomarkers trying to understand if you have a certain gene pattern, these certain structures or signatures. I love the word signatures because it's so individualized, right? They're finding these different subgroups of genes with people who also have family history of autoimmune disease, and they're testing them to determine, could they prevent RA from happening if they treat them with XYZ. All right, now you got to remember there's kind of an ethical conundrum here, like these are harsh medications, and if they don't, how, so there is that that we'll have to consider if it ever makes it to the clinical setting or in your doctor's office. In saying that, the studies that we saw a little bit here, but they reported on the last one as well, was that they have not been able to prove that they can stop RA from happening. Okay, that's an important takeaway. However, they were able to prove that they could delay it. So it still ended up happening, And those people who have like rheumatoid factor positive or ANCA positive or these seropositive markers in their blood tend to have worse outcomes, we know, and they tend to break through that barrier. In saying that, it does show us that potentially even catching it that early, though, it's possible that these are the people that have the best chance for remission because they caught it early, they started treating it. It's very possible that they will then be able to be tapered off and possibly never have another flare. That's amazing.
Yeah,
Agreed.
that is. And, I just want to highlight, research also shows that those who have fast, effective treatment early on are the ones that can achieve remission and have better outcomes. So that is actually life-changing for people with rheumatoid arthritis, if we can get that early treatment.
100%.
I just wanted to throw out, I can see the comments now, and shout out to Christina Montoya. She was saying also known as preclinical studies. That's a great term. We got to add that to our glossary. Okay, so a couple other just points here for remission. There was a lot of talk about remission and when to taper off treatments, and it's called drug-free remission. There were some that we saw at pre-conferences, I think last EULAR and last ACR in particular, that talked about this. So what you will find the longer you go with us to conferences, we'll see the same study showing back up, and then they're reporting the next phase. So seeing the way that research kind of loops back and goes through its processes, I think it's interesting. So one of the things that I saw, just a couple bullets here, that there was a precision medicine for lupus session that talked specifically about being able to taper off of steroids. That's a really big thing in the lupus community. That is always prescribed in the beginning. It is in all of our diseases, they are doing a lot of studies on steroid tapering. So this is an example too, even though they talked about it in lupus, this is relevant for anybody who is on steroids. It is a huge, huge movement to do what we can to get patients off of steroids, because we know that long-term use is not healthy for many reasons, bone brittle. And as we start aging, which is, we didn't see any here at this there was one, but we didn't attend that one. There's another new trend in aging because we're the first population that's using these drugs and then getting older. And so we have to try to get off of steroids because our bones will naturally get more brittle, et cetera. So that one, there are some studies showing that it is very possible to, when you're controlled on a biologic, to taper off of steroids. The other thing that was talked about was there's many studies in the past trying to test how can we pull patients off of these biologics. And what they did learn is it has to be a slow taper. Cold turkey or just stopping abruptly, they said all, so I don't know if that was 100% or 99%, but they said all people were rebounding. So what they do in these studies is they start to pull you off of the medication, and they see how long it takes till you flare again. And in some cases, there's like a certain percentage of patients that get to, say, a 6-month marker or a 12-month marker or a 24-month marker, and they're still flare-free. And so that is considered the drug-free remission, and that's why they know it's possible. However, they also learn that when they're doing these doses of putting in practice for remission and pulling us off of our treatments, it has to be done in very certain increments in order for our bodies to not have a rebound, essentially. So that was a really cool thing. Other than that, we will be talking more about precision medicine as we go through, because it was everywhere. And one of the things we're not going to do is we're not going to go into detail of things that we talked about in some of our pre-reviews. So we mentioned this Go With Us program. We give these daily updates or semi-daily updates. So what we will make sure that you do is we will have the links to those for you so you can see. One of them was on undifferentiated connective tissue disease and mixed connective tissue disease, a very strong passion of mine. I did a whole report on that, so we'll make sure that you get that link. and all of the other links, and make sure you sign up at aiarthritis.org/conferences. So you just get them all in one nice bulleted list. In saying that, a couple of the points that I wanted to bring up, and this is our bridge between early disease and developed disease, is that undifferentiated connective tissue disease in this respect is essentially before you're diagnosed. So this is when you could have any symptom of that any of us have with our disease, smush them all together, and those are symptoms of undifferentiated. And what it essentially means is the disease has not developed enough in order to get a diagnosis. So this, I was so happy to see being there in an entire session on its own. Usually it had this little bitty 10-minute call out. In a session, it had a whole session. And the other takeaway from it, we said years and years ago, patients said 50% of us have undifferentiated disease first, because it used to say 15% of us. And we said, that's bull, you know. And the reason we said that is because we felt it's just because people are not diagnosed with anything. We did a study years ago. We actually proved that 54% of patients really did have it. And I was very happy to report that they said it has now gone up from what they thought 10 years ago, 15% were undifferentiated, is now 30 to 40%. So that is good news for us. Why? That is good news because there's a focus on that early disease, the possibility to treat before it even develops into something, and keeping it mild. The milder we keep our diseases, if it stays at undifferentiated, that's not a bad thing. And I want people with undifferentiated to know, because I was that person and I was pushing for a diagnosis, but nobody ever told me that it's okay to stay there as long as I got treatment. So that's the takeaway that I want to say there. I'm going to turn it back over to Deb for developed disease, a difficult to treat, which is D2T. That is the acronym, was everywhere also. So difficult to treat and comorbidities. So take it away, Deb.
Absolutely. So this session was everything is difficult to treat, and it focused on difficult to treat RA, difficult to treat spondyloarthritis, and difficult to treat lupus. And some of the major pieces, they had some really cool slides, and is that something that we're going to be sharing later too, Tiff, as far as some slides that in our social media posts about things?
Sure, we can do that.
Yeah, there's a couple that I think everybody would be really interested to see, as far as what the whole picture looks like. And like at the center of it is difficult to treat RA, but then it goes into comorbidities, behavioral and lifestyle. Then down here was rapid radiographic progression, which is changes in your bones and in your x-rays, and failure to taper with the glucocorticoids like prednisone and things like that, and the DMARD therapies. And then it breaks out into probably 30 things under each one of those 4 things. So very interesting. But basically what the crux of who is difficult to treat for RA is you have at least moderate disease activity. There was failure of at least 2 DMARDs, and then you can't taper the prednisone any further, as well as rapid radiographic progression. So a lot of changes in your bone structure and deterioration in the different joints all throughout your body. So that was the major crux of the difficult to treat RA. As far as let's see, it actually, and there's a couple more slides that talk very specifically as far as the glucocorticoids. If you can't get below a certain number of milligrams, that's kind of what it's talking about, and different other aspects of that. One thing they do talk about as far as what future directions will be. And what the summary of that was is where you go for information is the EULAR guidelines, and they're changing and editing those all the time. As far as the prevalence of comorbidities, the pain and inflammation in difficult to treat RA, there's so much more future research that needs to happen, and clinical trials over and over and over. I saw so much information on clinical trials. As far as lupus, difficult to treat lupus, one thing they definitely talked about, what makes it even more difficult to treat, was the fact that you have aggressive lupus nephritis. There was so much information on lupus nephritis that I learned a lot as far as that goes.
And lupus nephritis being the advancement of the kidneys to systemic lupus.
Correct. And as far as lupus psychosis, that was something that I saw focused on a lot in at least 2 sessions. Lupus psychosis is literally you start to hear voices in your head of what, and it's terrible things that these patients are reporting back to their doctors, as far as these voices are telling them to stop taking their medications. They're telling them to ignore their children. Terrible psychotic episodes, as well as lupus and infection. That was also another piece that makes lupus very, very hard to treat.
We actually there was actually a lot of that in the brain one, that brain and lupus, and then brain and RA too. So you'll see that a lot in that. A lot of the things that are referenced in one session will be referenced in another. So it's a very good example of that.
Yes. And the spondyloarthritis, again, nothing that really jumped out. A lot of the similar themes, again, like Tiffany was saying, the difficulty in tapering from glucocorticoids. That was a resounding theme that I saw in all 3 of those sections. And spondyloarthritis, obviously there's different pieces that the non-radiographic versus radiographic, that means your x-rays. And with non-radiographic, you don't have the evidence on x-rays like the radiographic, which actually has changes as far as that goes. So that's where I'm going to leave that as far as the difficult to treat parts. Okay.
See my screen?
Yes.
All right.
Sure. So and that is exactly one of the slides that I was talking about.
All right. I'm going to add a little bit to what Deb said, and I'm sorry, I don't know that I don't know if I can, I can get it a little bit bigger. Okay. So what I wanted to point out here makes it a little blurry, but there's a couple things that I just wanted to point out really, really fast, because I think this will substantiate what Deb was talking about. So EULAR gives their definition of difficult to treat. So what I found really interesting when they first put this up, and I put a big question mark on my piece of paper, and that was failure of over 2 biologics equals difficult to treat. And I went, who hasn't more than 2? So I kind of went, huh? And so so I wanted you to just see what, how serious that it's being considered, that we get on the right treatment at the right time for the right person. So that's the takeaway that I want there. But I have a really cool breakdown I'm going to walk you through to show the evolution from what they're calling difficult to treat to polyrefractory. Refractory meaning it's not responding to anything, and poly is more than one, right? So I want to show you that equation because I felt it's good to know the difference as a patient. So I also have that one up right now. So let me just do it. You're not going to be able to see the little words over to the side, and don't worry about it. You don't need to. The important thing to follow along with what I'm saying is the stuff to the right. Okay. So this is when they talked about let's study what really difficult to treat means. And again, this was RA, but this is applicable to anyone. So they started with 1,591 patients, and about 50% of those, which you go down to the 73, were the ones that needed more than 2+ biologics. So in that respect, 50% of patients would be considered difficult to treat. No shocker there, because like I said, most people have been on more than 2. But they said, okay, everyone can't be, or 50%, that's a lot. Where are we really focused on the truly refractory? Like I would say, Deb, you would classify somebody who's been on everything, who needs the new innovative research. So what they did is they broke down in these registries, and it was about 15% of that 743 actually still had what you would classify as moderate to severe disease. So they go in the doctor's office, they do their clinical workup, and they weren't feeling well still. They needed some kind of tweak in their medication. They were not considered mild or even close to controlled disease. All right, so now we're getting somewhere. Of those, only 2.5%, so now we're down to 41 out of 1,591, still had inflammation in the ultrasound. And when they went down even further, only 1%, 18 people, ended up with truly polyrefractory, meaning that in the clinical setting, that they really want to start looking at why patients are still reporting in their global assessments, why we are still saying, I feel terrible. But in this study, that's why I wanted you to see it. They're saying, science is saying only 1% of us are truly polyrefractory and not responding. Why are what patients saying different? Let's just know on that. So go ahead, comment on that, if you will, in the in the comments. So I thought that was just something worth talking about. All right.
And what I find interesting is that both of us saw 2 different sessions. You saw that one session about RA, and I was in the difficult to treat, but I also noticed that the people that were presenting, the person that presented on RA and the person that presented on lupus, and they were trying to one up each other. They're like, well, you're saying yours is really difficult. Well, let me show you my data. And it was just the banter going back and forth. But I'm seeing the same thing as far as it is really difficult. And they're like, everything's difficult to treat. Well, it kind of is,
yeah,
because
that's a good title.
We're all very individual. You're exactly right.
We have an outline here, but because Deb and I have had to monopolize the conversation because those are the sessions we attended, we're going to jump ahead and give the floor to Miss Eileen, and then we're going to come back to comorbidities, because as I look in her notes, they talk about comorbidities in some of the sessions you talked to as well. So we'll just swing back around and add to what you're going to say, Eileen.
Which topic do you want me talking about first?
Well, I'm looking at our outline here, and we've got here you saw buy one get 4 free. Okay. You talk. I see support. You just any order you want to go in is fine.
Okay, I'm gonna go by my note, where I've kind of taken the golden nuggets that I learned in the sessions that I attended. And by theme. So my first theme is exercise. And one thing I noticed there was a big sign that said exercise is key. And having been involved in so much research previously with exercise, these sessions were really kind of sparked my interest, and I wanted to see if I can learn anything new. I did learn a few new things, but a lot of it was also clarification that what's going on in the research within Canada is also transparent across the world with other places that are researching exercise and arthritis. Everywhere says 150 minutes of moderate to vigorous intensity exercise per week, which is about 30 minutes per day, is key. One thing I did notice is in Europe, they said strength training twice a week, 20 minutes, whereas in Canada, we say 3 to 4 times a week, and we don't specify minutes. So I thought that was kind of interesting, and I kind of want to dive in and understand that one a bit more. Why is that so different between what Europe was saying versus what Canada is saying? One thing I did hear, and I've heard many times before, and I think is very important for any of us, my favorite golden nugget about exercise is it makes our medications work better. It helps reduce that inflammation and just get the blood flowing, and our medications work better. So if you're wondering, you're taking your medications, you're feeling like you could add a little bit more, movement might be the key. Exercise also reduces our risk of comorbidities like heart disease and such, but it is not a complete end of risk. We should know that our diseases are ugly, they could still happen. Exercise improves mental health, but when we stop exercising, our mental health problems can increase. So I definitely feel that one, having lived that experience many times. When I can't exercise, I do worse, not just physically, but also emotionally. They had one really interesting measure of fatigue. They said that exercise reduces fatigue by 20 to 40% in rheumatoid arthritis patients, however, not for lupus patients. That is also something that I've seen in Canadian research, where they have found exercise reduced pain and fatigue in rheumatoid arthritis patients, however, not lupus patients. So I kind of want to know why. Why is that? However, I have never seen it measured by percentage of like how much fatigue is reduced. So that's one of my favorite golden nuggets that I found, is the 20 to 40% that exercise reduces our fatigue. And there was a lot of similar research that I have been involved with in Canada. And so it was more so motivating to get me moving again. All right. And if anybody has any other questions regarding exercise, please just ask. My next session was mental health, and there was some interesting facts about mental health that I saw during my sessions. Now I'm talking about kind of all of my sessions and the themes in one. I'm not naming off what's like the session, like there's a bunch. I'm just going with the themes, the golden nuggets, because you're gonna get a pile of information. You're not gonna remember exactly which session, who said it, where they're from, all that jazz. However, I thought it was interesting to hear people with depression have a lesser chance of remission. Anxiety and depression is higher in patients with ankylosing spondylitis and psoriatic arthritis versus rheumatoid arthritis. I kind of wonder, why is this? Could this be because there's more medications for RA, or could it be because AS and PSA tend to be more diagnosed in men, and men don't typically reach out for help? So I'm kind of wondering, what is the cause of that? Like that, I feel like that itself is a study. However, I know they're finding more women involved. But
okay, I'm like, that's an old.
There is still, that is an old one. They are, okay. But I do wonder if that has a contributing factor. And then depression and anxiety heighten our pain perception, and pain causes higher rates of anxiety and depression, meaning it hurts even when we are, or it hurts more when we're in a depressive state. So if you're not feeling good emotionally and you find that your pain is heightened, then that is very true. And then of course, pain and depression worsen each other. And people with depression are more likely to develop rheumatoid arthritis, which with me, I was diagnosed with clinical depression at 17 and rheumatoid arthritis at 29. My diagnosis honestly isn't that big of a surprise to me, because I was dealing with mental health problems before. So now I advocate that we should definitely treat our mental health, because mental health problems can turn into significant problems for us. And yeah, and that also means that I have a lesser chance of reaching remission, and people with depression and rheumatoid arthritis have greater comorbidities like obesity, diabetes, heart disease, and such. And then also, depression does really significantly impact our quality of life, along with the disease itself. rheumatoid arthritis or other forms of arthritis. So this one I did not learn in a session. It was when I was sitting down for dinner with some of the Arthritis Research Canada staff and researchers, rheumatologists, and I asked them about why we get brain fog. And they said some interesting facts about our medications don't touch the brain because of the blood-brain barrier. I cannot explain why, but that is one reason why our cognitive dysfunction and depression can be bad. We'll obviously go more into the brain thing, but I just thought that was really, really interesting, and probably one of the most interesting facts that I learned during my time at EULAR, and also highlighting that you learn so much, not necessarily in the sessions, but by the networking and the conversations and the people that you meet, because you have the opportunity to ask researchers and clinicians questions, and it's longer than the time that you get to spend in a doctor's office with your own doctor. So it's like free healthcare advice. And then so I was really interested in the non-pharma sessions. However, I found that I was hoping for diet, exercise, things like that. It was actually more focused on support and what our support looks like and how we can support the support. So in my honest opinion, a little bit of a letdown on those, because I wanted to learn a little bit more about non-pharmacological interventions for us. And so I've already highlighted what we learned about exercise. I think that's the main non-pharmacological intervention that we can learn about right now. And yeah, I'm going to pass it back to Tiffany.
Right. And, something that I'll just take the opportunity to mention, because we do like to report back these nuggets and things that we're learning. And again, keep in mind, we only have a certain amount of time to try to get all of these nuggets out to you. So we will continue the expanded as much as we can, and put in the comments things that you want to know more about, so we know what to keep reporting back on as we put more of this data out throughout the year. Okay, so that's really important. In saying that, one of the things that happens is the only things that are presented at these conferences are when the research is ready to be presented. And so it really is tricky, because Deb is a dietitian by trade, a retired dietitian. So she always is the one going to the diet ones. And we were kind of like, wah, wah, because there was one session and it only had like a little bitty segment, I think, of diet, and happened to be when we were at a meeting and we weren't able to go, but it was just this one little this. And that's just what happens sometimes. It doesn't mean that there are not studies happening. So I want to make that really clear to people who are tuning in. Don't feel like, oh my gosh, why aren't they talking about diet, or why aren't they studying it? They are. It's happening. It's just not ready to present. And so chances are, because we saw more exercise than I've ever seen, it's just so happened that all of those types of studies were ready to report. So it's going to come back. It's just, when are they ready to present something different than was presented at the last time? So it's just a cycle kind of thing. So just don't feel because we're not talking about it that it's not happening. Okay, so just wanted to clarify that. The other thing is this is another good example of how things overlap, because Eileen and I will break out in a couple minutes into our favorite session was the brain. And you can see that there's been a lot of talk about the brain. We're going to talk more about the brain fog and the neurological, which was covered in this one. But we've been hearing a lot over the last couple of years about depression, about the brain pain. With pain, you feel it in your brain, whether you know that or not, before you actually feel it. So your brain has a lot to do with how you feel pain. So even though we didn't see anything on that this time, I know that brain pain kind of thing, I know that research is also going on. And we're really excited to see more of that as they're ready to present in future conferences. So make sure at aiarthritis.org/conferences, you do sign up so that you can always keep informed as we learn on this building. In saying that, we're going to jump back to a couple facts here, some good nugget takeaway for comorbidity. So one of the things I do want to preface is the word comorbidity. Okay, so which I'm also not seeing as much of multi-morbidity, which was a real hot topic a couple years ago. And multi-morbidity was when you have an existing disease that lives on side of your disease. So for example, I've been diagnosed with anxiety years ago. I do not have anxiety from my spondyloarthritis. Some people do. If you did, it would be a comorbidity. It's happening because it coexists as part of a manifestation of your disease. A multi-morbidity is having to treat something separate, and they have to think about the pharmacy and treating things alongside. How is this going to affect this, right? So we did a whole episode, talk show episode that aired that Michael will share in the chat on what is a comorbidity. So I think it's important for patients to think about, is this something that's happening as a manifestation that derived from my condition, or is it something that's a normal symptom? For example, lupus, mentioned earlier, the brain is very involved in lupus as maybe even a first symptom, whereas brain fog symptom, right? In whomever. But some of the central nervous system things that happen in our diseases with RA or spondy or others, that would be considered a comorbidity because it's the result of uncontrolled inflammation that is worsening and causing the inflammation to travel throughout your body and cause additional things to happen. So it's a really important topic for people to understand comorbidities. Is it a symptom? Is it an actual comorbidity? So we're going to dive more into that as an organization and some of our educational information, because that's really important as you living with the diseases to understand. In saying that, some of the highlights that we've seen in the past, tons of research on heart. And, you know, Eileen, you and I were sitting there, because sometimes chat just happens when you're not at the sessions. We were sitting there in our living room and we were talking about this. And I said, you know, last EULAR, Dr. John Edsdale, who used to lead Arthritis Research Canada, I'd seen him talk last year about once you're diagnosed with RA or similar diseases, your risk for heart disease jumps up 20%, just because you're diagnosed. And you were telling me, Eileen, that Canada has taken a really strong stance on recognizing heart as a comorbidity. Can you just mention a little bit about that? I think it's a good model a good thing to model.
Yeah, so I feel extremely blessed to be on the Arthritis Research Canada Patient Advisory Board, because I have access to knowing a lot of the ins and outs of what's going on in my country with research. And Arthritis Research Canada, well, they have the label Canada on them. Honestly, they are doing amazing research around the world, because comorbidities, heart disease and whatnot doesn't know borders. This affects everyone living with the disease. And so there have been quite a significant amount of studies and work and awareness built up by Arthritis Research Canada around how rheumatoid arthritis or inflammatory arthritis does affect our hearts. And that actually speaks personal volumes to me, because I have an aunt who was diagnosed with rheumatoid arthritis many years before I was, who actually passed away from a heart attack. So that's always been something that I've been kind of, you know, looming over my mind, aware of, and knowing that even though rheumatoid arthritis will not kill us itself by the disease, but it's these comorbidities and these problems that arise with it that can, and they've also noted that arthritis often comes first before heart disease and whatnot. I know that also, that includes the non-autoimmune forms, but it is also definitely higher in the autoimmune forms, because we're talking the inflammation. It's what arthritis does to us, not being able to make us move as much, depression, just not taking care of ourselves. There's many different reasons why we kind of end up with these problems. And yeah, Arthritis Research Canada is definitely, I feel like, leading the way in some of this research. And it's something that I think patients really need to be aware of and need to talk to their rheumatologist about, because
right there.
is this being brought up to them? Like, how do they know? And like, it's really interesting. One fact I learned that when I was at EULAR, that it takes up to 17 years for the research actually to make its way into practice.
Yes, that's one of the things with precision medicine that they're hoping to change. So with precision medicine, the thought is that as we're starting to get closer into bringing subgroups into clinical trials or into research. So think about this. This is one of those moments, again, that we like to do in our reports. Our reports are not just spitting you out facts. It's about, we're living with the diseases. These are things that we should understand, you know, as a community. So everything that we're presenting has gone through some kind of research. It has gone through some kind of trial, some kind of organized study that involved people, and it gets more people and more people as the phases get bigger, and then it eventually is approved and put into practice. So one of the things that science is really trying to do with precision medicine in particular is, before, all of those people in those clinical trials are what we call general patient population. That means you're the typical RA, you're the typical psoriatic arthritis, you're the typical spondyloarthritis. And let's be honest, how many of us are typical, right? Hardly any. We say atypical is typical.
Sometimes it fluctuates.
And it is very difficult to say I am classic anything. And clinical trials do not consider comorbidities. They do not consider, if you have RA and Sjogren's, for example, boop, you're out. If you have potential heart disease, boop, you're out. So it's very unrealistic. And so the hope of precision medicine is it's zeroing in on different subgroups. And if we can show the data, then that could actually expedite how these treatments are getting to us. So there is some hope in that. The other thing that I just wanted to mention about the clinical trials, because this is important for you to know, we're going to talk about it here a little bit later, is if you've ever wondered why so-and-so does great on one biologic and then you don't do, and it does nothing for you, right? That's what precision medicine is all about. That's why we need to work on how these research studies are conducted. The endpoints, the things that are important to patients that need to be studied are called patient-reported outcomes. Having your voice counted when they're taking all of these boxes that they need to study, things that matter to you, all of that stuff needs to be, and is being taken into account. And so that's just a little side note to also check out our conferences and sign up, because we also will help you if you want to be more involved in research and have your voice count on these research teams. Just a plug, side note on that. In saying that, what happens is, because we have this general patient population of people who represent the classic textbook and have nothing else wrong with them, and often are biologic naive, mind you, meaning they've never had a biologic. So these are often early in the disease. So it doesn't even represent those with us for 15, 20 years into it. They get the product gets to market, and it shows like maybe a 70% improved response rate. Let's just use that percentage as an example. And it gets to market because it proved to be good for these patients in the clinical trial. But then only really realistically 30%, 40% of people actually, when it goes to market, responds. So it comes down from the 70% amazing drug to 30. And it's simply because now it's hitting the rest of us, and it's not going to work for all of us because we don't check the boxes. So that's just a really important component of all of this for you to think about when we're presenting all of this, and think ways that you might start going, yeah, I want to be more involved in how all of this pans out, because in the long run, you're the end user, right? You're the one who this stuff is going to matter when it gets to clinic. So sorry that wasn't in our script, but I couldn't help myself. I feel like those kind of things are important.
Yeah, this is all important information for sure.
Yeah. I think it's so important for us to be involved in research. I just want to highlight that.
I see, shout out to Charmaine, who's commenting away from Dragon Claw, and she mentioned OMERACT. We are very good friends with OMERACT. Deb and I were one of the 18 patient research partners invited to be at OMERACT in Colorado this past year. And that is outcome measures in rheumatology. And I have been a member since 2016, and I'm on, I think, 5 or 6 of the working groups. So if you want to learn more about the work at OMERACT as well, we will definitely be wrapping that into our Go With Conferences program. And I have a very strong inside track to get you involved in OMERACT if you are at all interested in being part of the research team. Alrighty, so a couple little nuggets that I just want to throw in here. We've evolved from the heart to the lung. So there was ILD, interstitial lung disease, everywhere. So here's an example of this is where the research is going. There's enough data to show that lung involvement in our diseases, and there's a lot in RA in lung disease, but it's not just RA. There's sarcoidosis, there's scleroderma or systemic scleritis, psoriatic arthritis, Still's disease. So this is not just narrowed down to one disease. I did not have time to go to all of the sessions that included it. Deb, I don't know if they mentioned it in any of the comorbidities you were in.
They did.
Is there any nugget of information to share with it? Or
there was nothing specific, but it was again referenced, and more than I've ever seen it referenced.
Yeah, for sure.
So,
It was one of those that a few years ago everything was heart. Now there's some heart that they're talking about, but that's how the research goes, right? We talked about that. So what's going to happen is we're going to see the heart come back again. Maybe it's going to be ACR at the end of the year. Maybe it'll be next EULAR, because they're in a different phase, right, of studying. And now we've got lungs. So this is one of those segments that stay tuned. Subscribe to AiArthritis.org/conferences, because this is the kind of thing we have access to all of the sessions. We're going to keep watching, because this is a piece we have to see. It's just what happens when we're there. There's like 10 sessions going on at the same time that we are interested in. There's like 20 or 30, but we're interested in a handful, and there's only 3 of us. So we just can't possibly see everything, but that's when we know we have to go back to, and we do want to put it on your radar if you want to Google it or learn more about how it's relevant to rheumatic diseases. Eileen, did you have something to add?
Yes. So one thing I did notice about the ILD is that there was a lot of emphasis about it was the #1 killer for people living with rheumatoid arthritis. I have also noticed that said about heart disease. So they're both really bad, but which one is the one that we really need to watch out for? That's something that I wonder. And it also, highlight that the first time I heard about ILD, I asked my rheumatologist for a lung exam because I just wanted to make sure. It's unfortunate that, as a patient that I have to ask my rheumatologist for that, but I do think it is important for patients moving forward as we learn about these comorbidities. If your rheumatologist has not addressed these to you, ask about it, ask for a heart exam, ask for a lung exam. It does no harm.
Yes.
100%.
Oh, sorry, go ahead, Deb.
No, I was just going to say, I have been asking for cardiovascular screening because I've had so much heart disease in my own family history, and having an inflammatory disease. I've asked for it for probably the last 5 years because it's everywhere in research. And I keep being told, and I had been told until now, you need to wait for symptoms, that you can't do that yet. So, and again, I'm very persistent and I keep bringing it up, but I kept getting, no, you need to wait for symptoms. And now I am actually in the midst of it because I wasn't going to stand for that anymore, because underlying symptoms are showing up. So just be persistent. I can't say that enough. You need to know. You need to be very persistent in asking your doctors because you know your body best.
Yeah. And also keeping up with the research, because that's how I know about these things. That's how I know to ask my rheumatologist. Unfortunately, my rheumatologist is a little bit more proactive. When I say I want something, she will do it. But that's also because I say, so at this research conference I went to,
right.
so
I think that I'm glad you said that, Eileen, because another thing that we aim to do at AiArthritis through this Go With Us to Conferences program is we're giving you information. We're trying to give it to you in a digestible way. That's why when I shared slides, I said, don't worry about that little the little jargon. That doesn't matter. We have to look at it through a patient lens focus on the nuggets that come through. And in saying that, we also hope to help you create talking points and guidance to bring this back to your rheumatologist, because we know not all rheumatologists are going to be open to you saying, hey, I heard XYZ. That's the whole Dr. Google syndrome, right? Where some of them will push back. So we also, in a lot of the guidance we've started to create at our organization, this should be no different. We can create some tips for you to start those conversations with your doctor. If you do not have the kind that are as open as maybe like Al, shout out to Al Kim, my rheumatologist. He's just like, all right, whatever you want, Tiff, that's cool. Like, because he doesn't, push back on anything. But in saying that, that's a different situation, right? So
I've got a shout out to Charlemagne, because she just said, hence the importance of education for us. We need to be in the driver's seat. Yes, 100%.
And also quick shout out to, I wanted to say, Christina said, I joined the OMERACT Sjogren's working group. See you there, sister, because I'm in it too. So I was actually at OMERACT when they presented their first presentation ever. So Sjogren's is something that I was actually going to mention later, but why not? We're talking about it now. Sjogren's had a big presence at this conference. And while we're not going into very specifics as far as each disease and everything they said about it, because that just wouldn't be fair. You don't have enough time to say that for everyone. But I did put some notes on Sjogren's in particular, just for the fact that it was such a feature and because of the OMERACT working group. So when I was in Colorado a month or 2 months ago now, the Sjogren's working group presented that they are finally going to be able to start working on clinical endpoints, meaning the things that are studied in the research, in the trials for treatments for Sjogren's syndrome, which there are none that are on market. It's kind of a borrowed treatment. And so this is really exciting for Sjogren's, which is now, by the way, called Sjogren's disease, not Sjogren's syndrome. And I was so happy. I was in the room. I was the patient partner in the room, but they had our friends from Sjogren's Syndrome Foundation and Sjogren's Europe, who I know well, Kathy Hammett, shout out, and she emailed me back and said, oh my God, I saw you in the room. And so it's just exciting that we're all coming together for working in research and making sure Sjogren's patients are represented. So a couple more quick nuggets for the comorbidities. And when we circle back, I do have some slides from the Sjogren's one, just because they were, I just thought, good examples of things that we see that patients might find interesting. We're talking about cardiovascular. Some studies did prove that certain drugs, including methotrexate and TNF inhibitors, which are like your Enbrels or Humiras, it's the TNF inhibitor, TNFIs. That's just the mechanism of action, right? So that's what it's inhibiting your body from producing those, and that's what helps some people, right? And then you'll see IL-6 or IL, whatever, and so that's just targeting different things and different mechanisms, and one of those things about why one treatment might not work for one another. But it does say that those particular drugs, methotrexate and TNF inhibitors, can work to improve cardiovascular risk. So it does it, if you want to know how, it was through inhibiting plaque formation and stabilizing high risk lesions. So that was interesting.
Yeah,
sorry, go ahead.
I just want to say that is interesting, because in my head, I would assume it's because it reduces inflammation, not what it does there. So that's really cool. There's a golden
nugget, right? So that was one that I definitely wanted to mention. And the other little takeaway that I wanted to say from this, Deb, you mentioned this to me again. It was one of those after conferences when we were talking, and you said that the management of comorbidities and this multi-team, which we've talked about forever in a day, that our doctors need to speak to each other, that you saw that as a theme.
Yeah, and especially in the comorbidities and multi-morbidity session, they talked about it literally as being a fragmented healthcare system, that you have your rheumatologist up here, but then you have your cardiologist, your diabetes doctor, all these other specialists, and nobody's talking. And you got to put the patient in the center, and everybody's got to be communicating back and forth. And they were just talking about how much work we need to do on that. And whether that be, because I find that I'm doing all the connecting, because like prior to surgeries, I'm trying to get my rheumatologist to talk to my orthopedic surgeon, to talk to, back and forth, and everything affects everything. And they definitely said also that most rheumatoid, so they call them RMDs. So rheumatology, I'm like
rheumatic diseases.
Yes.
Rheumatic.
So all of the rheumatic diseases, they're saying that most patients are multi-morbid and have multiple comorbidities and multi-morbidities, which cardiovascular disease, diabetes, depression, cancer, all these things, but they need all of the doctors to communicate more, and they need to treat the patient, not the disease, which I also found fairly fascinating as well. So again, stay tuned, a lot to come as far as that goes. I have a really cool slide that actually breaks the diseases down to RA, spondy, lupus, and talks about what the prevalence is. For instance, one couple different things. For lupus, they talk about like cholesterol and lipidemia, that you're up to 60% of lupus patients have that issue. As far as depression, depression was highest in RA as well as lupus. We're talking 46 and 48% of patients. So again, there's so much interaction, and so many of us don't just suffer from, and I don't even like that word. I don't even want to say suffer. I'm gonna nix that. Just the fact that we all have these diseases, and it's not just one thing. It is hypertension, cardiovascular disease, diabetes, osteoporosis because of just getting older, as well as our medications that are causing that. So many different things. And cancer is another piece that is definitely developing more. This time is the most I've heard about cancer being recognized as being another piece of our diseases.
Yeah, and that also we're going to get in, and I'm going to start spitting out a bunch of stuff here that I have in the list so that we can start to get to a point where we can wrap up. We did start 15 minutes late because we had technical issues, so we're going to run 15 minutes over. So just letting you all know that. In saying that, oh shoot, now I just lost my total train of thought. What did you just say, Deb?
I'm talking about cancer and depression.
Oh, thank you. So one of the things I just wanted to throw out there too, as an international organization, one of the things, and I don't have the slides pulled up, but there was a PARE, which is the patient organization sector of EULAR. And I'm very proud to say that AiArthritis was picked to be the North American one patient organization representative to be part of International PARE or IPARE. So they did present a little segment of that. And we'll share those pictures with you in the comments after the fact. I don't have them pulled up for you, Michael, but I know you'd share them if you knew where they were. And it just shows a few of us that were selected, and we're just really proud that we're representing all of the patients of North America. So not even just like United States or just like everything in North America. In saying that, cancer has been recognized a lot in the European public policy because there are ties that if our diseases, it's just inflammation. That's why you're going to see a lot of movement towards inflammation as the umbrella in studies. And it's because it's causing things which Eileen and I will tackle on Alzheimer's, dementia, cancer. So those are three things now that we all really have to think about when we have our diseases, because it's the result of uncontrolled inflammation. That's the bottom line here. That's why we're seeing it so much, and it's starting to come up. Now, we don't want to say that as a, oh my God, I'm going to get these things. Don't take that as a freak out moment. The goal is it's just we're at higher risk. It doesn't mean you're going to get it, right? It just means it's a good reason for us to really think about controlling our diseases the best. And when we talk about comorbidities, tying back to what Eileen said here, the holistic approach, biologics or pharmaceutical, especially if you have moderate to severe, there are people with mild disease where they may never have to use those, right? And not even recommended, to be honest, if you have mild disease, because they are very harsh. So, but if you have this moderate to severe and you want to get your disease in control, it is recommended to use the pharmacologic, but it's also recommended for this exercise, for mindfulness, for get the depression down. All of that increases inflammation, the diet, all of it together. And I want to give a shout out to UCB Pharmaceutical, and particularly the European peeps that we met with, because it was the first time ever in a meeting. They said to us, we would like to give your organization, we would like to consider giving you a grant for your work to educate on the holistic, meaning they actually, a pharmaceutical company wants to fund education about non-pharmacologic. I've never heard that in all of the years that I've been doing this. And I just went in the meeting because I said, that's a dream. And I was just really, had to give them a big shout out, because the fact that they brought it up, it was, I thought, pretty cool. I almost cussed. I almost came out. I stopped myself. Okay, so I'm going to spit some other things out here, just basically some facts. So I'm going to give you a couple examples again of precision medicine so that you understand where we are in this and what it means to us. So this is not new information. We know that certain biomarkers, certain blood markers, if they're positive, it means worse disease. I think that just makes logical sense. If you have high inflammation levels, chances are you have worse outcomes. I think, again, common sense. And saying that, now they're starting to go in. It's funny because they can't tell you what they're studying. They can't tell you the particle inside the joint, this little autoantibody inside the joint. So they call it joint ID 178. So it's like code, because they can't present the research and let everyone else see what they're studying, right? They can't share the secret molecule, so they call it the code name. So they did a study on going in, it's not quite a biopsy, which is a whole other side of precision medicine and getting these tissues, but they did look at studying joint-related proteins and how they could predict disease and outcomes, like who might achieve remission. So again, we're going back to that, trying to see how the different autoantibodies that live specifically in your joint. And what they found was that there was a decreased swollen joint count in 41% of patients at 6 months after after treatment, if they had this particular autoantibody inside their joint. And then they compared it to, they called it joint ID 199. So if they were joint ID 199, so they're taking this other antibody, then that in particular, when you added to it, then it had increased, I believe it said, so don't hold me to that, increased the chance. But what they found to be important about that was, we hear all of this stuff about rheumatoid factor positive and ACPA positive and all of these different biomarkers making disease worse, but the people who were in this study were all ACPA and RF negative. So the point and the takeaway as a patient is, don't think just because we talk about all these biomarkers being positive, now they're talking about biomarkers that have nothing to do with the blood inflammation. They're talking about the joint autoantibodies. And so these are for the other people who are negative and are still having problems. So that's the part that's important for patients to know, is that we're doing all this other exciting testing in precision medicine that has nothing to do with the blood specific. So I wanted to mention that. Some other examples here were CAR-T studies. So we're starting to see these come up. You can Google CAR, C-A-R-T, and it's the first time that I really saw it come up in more than one. I saw it in Sjogren's, and I saw it in lupus and lupus nephritis. And essentially, it's when you take your own blood and your T cells, and they go off to a lab, and then they, and there's like this specialized facility, and then they return them back into your bloodstream, and it helps to your immune cells to find and fight off disease. So it's a whole other form of therapy that is extremely precision medicine, and it's very, very early. So don't think, oh, I can go to the doctor and ask him for him, her, they, CAR-T therapy. We're not there yet, but it's kind of exciting to think about these other ways of treating our diseases that have nothing to do with biologics, right? It has to do with taking our own blood and revitalizing it, putting it back in to our body. So I did want to mention that as well. And then I'm just going to jump down here really quick to some of the other, here it was, because Charmaine asked about JAK inhibitors. So I did want to just mention that I did go to one session on the management of spondyloarthritis. And again, I'm saying this because it really didn't matter if it was spondy or if it was this is applicable across the board. And one of the things that they talked about was this holistic treatment, prescribing exercise, prescribing this stuff, right? In addition to the treatment. So we go back to that comorbidity and the holistic and the multi-dimensional treatments. And they said, I did not know this. They said, they're recommending that rheumatologists, after the first 2 to 4 weeks of taking a biologic, which is often a TNF inhibitor, because that's often the first line treatment, if it doesn't work between 2 and 4 weeks, move on. That was news to me, because I was always told 3 to 6 months, and that one really kind of caught my attention. And they said specifically the data is showing that patients and their response 2 to 4 weeks into taking the biologics, the data is showing that they're exactly the same results at 1 year. Interesting. So I'm not saying again, run out and tell your rheumatologist, hey, change me after 2 to 4 weeks, but it's something as patients. Isn't that shocking?
It is. It is.
That is.
And after everything that we've heard, and again, the whole wasting time.
And that's the theme. That's what
yes.
you got to zero in on, and that's what we're
yes.
saying. Go to these conferences. It's like you have to think really broadly. What is this under? This theme is really under treat to target. It's really under knowing, aggressively moving and shifting per individual needs to see quicker outcomes, because 10 years ago, the word remission didn't exist in our diseases. Now it's a reality. It's something that can happen. So that's part of this new recommendation. Now, this is not in stone. This is not an official EULAR recommendation. This is from a session. Okay, and it was a recommendation in the session. The other part of that said that if you do fail one TNF inhibitor, you're likely to fail another. So it is recommended to change the mechanism of action. Now, I know that might not be possible in your government or your insurance company or whomever dictates what you have to step through in order to get your treatment, but there's finding, the data is showing that if you didn't do so well on an Enbrel or Humira, chances are you're not going to do so well on another one that's got that same mechanism of action, a Cimzia or whatever. So they're recommending in the spondyloarthritis case to move to an IL-17 inhibitor. and not so much in IL-23 or in IL-6. Again, those are just targeting different things. In saying that, the JAK inhibitors came up because that is newly indicated for spondyloarthritis. As you may know, it was indicated for rheumatoid arthritis a couple years ago. Many years ago. And then you might remember a couple years ago, there was a big fear because there were studies that were coming out. We actually have something on YouTube. Again, Michael would not know where to find it. I do. I can put it in the comments when we're done. But there was this big issue because the FDA, the Food and Drug Administration, said that it has a black box warning now. And what a black box warning means, that it is considered to have a lot of safety issues. And it was really based strongly on a study that showed some heart issues and some complications in patients. So there was a big freak out on it. Now, the thing to remember about it is the study they were referencing were for people 65 and older with existing heart conditions. So we did a whole little mini breakout segment. So if you want to learn more about that research and that time, we will definitely link that in the comments afterwards. I'll go in and I'll look where to find it and where to link it for you. But the overall thing that we're still seeing with JAK inhibitors, because there was a question about this in the comment, is a lot of the recommendations are saying it's just still too early to use it first. That's just the bottom line. There was a big debate on it, I think 2 years ago at ACR 2021, where they were debating, can we just skip over the other ones and go right to a JAK inhibitor? We're just not there yet. That's the answer. It's just what happens with the way that a lot of times we have access to our treatments is research dictates. So if it's been on the market a little bit of time, and especially if it has any type of new warning or complications, it just takes longer for that to be first in line. So that's the answer for that. That is everything I think I had for the precision medicine. We have a breakout here that we really wanted to do for the brain. And I think we have to do that and probably end on that because we have run out of time. And that means that the stuff I wanted to share with Sjogren's, I will put it in the comments along with the slides that I have up. So I'll literally copy and paste what I was going to say. You can read it and you can look at the slides. So we'll do it that way instead of me talking about it. Eileen, take it away. I've got some slides too for the brain. So.
The brain. Okay, well, we're definitely going to have to tackle this one together, as it was very scientific, but also had some great little golden nuggets, particularly just making sure I have my correct notes up. All right. So I found that there was a number of interesting things in the session that we saw in the brain, but also the conversation that I had with the rheumatologist, because I was really wanting to understand cognitive dysfunction better. So when I was going for dinner, I asked about that, and they said that the medications that we have don't touch the brain. It could potentially be the blood-brain barrier, and that's why even if we have well-controlled disease, we might still have cognitive dysfunction. And that was about all the information I got on that through the dinner, because everybody was kind of talking about 10 different subjects at once, and there was wine. But the session that we saw the next day kind of gave a little bit more explanation and touched on that as well. The things that I kind of really found interesting was that inflammation can actually alter our brain, making memory and cognitive dysfunction altered after high inflammatory stages, which I think I've definitely felt myself after, when I was first diagnosed and also experienced postpartum depression. My depression and my inflammation was never higher than at that point. And every time I do experience high inflammation, my depression goes really bad. My anxiety goes really bad. So there is definitely a connection there. And then the other really interesting fact that I learned was that it was kind of random, but it was like methotrexate lowers the chances of Alzheimer's, but sulfasalazine does not. Tiffany, you were also at the session. I was taking a lot of photos. Tiffany was taking a lot more notes than I took during that session. So
I can jump in, no problem. Yeah. So yeah, we tag teamed on this one. So I'm putting up a few of the slides that you can see here. So this guy, Christopher John Edwards, just FYI, Eileen and I loved him, and literally as soon as it was over, we walked right up to the stage and we waited for him to walk down. And before he got off the last step, we were like, hello. And so we talked to him and we just said he was an amazing speaker in the sense that it was so easy to understand as a person living with the diseases. Keep in mind, again, this was a scientific session. That means he was not there to speak to patients. He was there to speak to rheumatologists and researchers, but he did it in a way that it made complete sense. Usually I have to kind of go through and sift and tune out certain things. I did have to do that a little bit, but not nearly as much. It was very well done. And we asked him if he would come back and speak to all of you as an extension of Go With Us, and he said yes. So stay tuned for that. Anyway.
I just want to hop in and say that there is a few sessions in the brain, and the first few were so scientific and harder to understand, where this one I think was the most applicable to us patients. So that's why
there were some parts about lupus and lupus nephritis, but it was all very scientific, and it was really only about how to treat it. So it was for rheumatologists. I mean, it was not anything that we can really report back because it was testing different ways of treating it. But like Deb said, it was about the fact that with lupus, we talked about comorbidities earlier, it's not a comorbidity, it's part of the disease. So that it is definitely, the brain is a huge component of lupus. And so that is, that's what they talked about. So there was nothing to really report back to that. The different nuggets with this one was that we have these manifestations of the brain that we're talking about. So you can see here, and they had a whole bunch on how it affects pain and how it affects anxiety and how it does depression. And you can see these kind of inflammatory, there's our key word again. What it's basically saying is the things in our molecular structure, the things happening inside that are creating the inflammation, they call it systemic, meaning it's full body. And it's hitting those, you see those levels of IL-1, IL-17, TNF. Those are all these individual little cytokines. Those are the things that your biologics are targeting, because that's why you see TNF inhibitors, those type of things. So these are things happening in your body that are inflaming. And in certain diseases, they inflame more than other diseases. And when they're heightened, it's increasing the inflammation, right? And in this case, those are the areas, the IL-1s, the IL-17A, the IL-6, the CR, all of that is what they believe is triggering the inflammation in the brain in specifically. So that is a key kind of scientific way of explaining it, I think, in a easy patient to understand way. In saying that, they talked about, and it says I have a slide. I'm frantically trying to go through my slides over here to find it. I keep pulling up the wrong one. Let's see, got one over here. There's another one. Okay, so this shows you what the inflammation of the brain looks like. Again, don't look at it with all these, what is all that? Doesn't matter. It's cool. It's just a cool image. Okay, it's showing you the activity of how they measure inflammation in the brain. And specifically what they were talking about is there are challenges in the treatment to the manifestations when it happens in the brain, and that's specifically about the nervous system. And one of the things that they talked about was the nervous system in particular is the part that's anxiety and depression. Brain fog comes out also when we're talking about the different nerve and the nervous system that's affected. And then they also mentioned that we can't forget that there's RA in rheumatoid arthritis. The nodules could be pressing on different nerves in your body, and that also can start to create different responses that you're feeling in the brain. And even though vasculitis is not as common in RA anymore, that is also something that is a neurological thing as well that often happens. Like, I'm going to stop sharing for a second. Like Eileen said, and I do have the slides and I just can't seem to fluster I'm flustering myself here trying to locate them on my other side of the screen here. But as we talked about, they talked about that when it comes to Alzheimer's and dementia as well, it's at RA, and again, we're just saying RA because that's who got studied. It does not mean it's probably applicable no matter what disease you have, but you have an inflammatory disease. 4 times more likely to develop Alzheimer's due to chronic inflammation. That's the key. It's due to chronic inflammation, not just you've got 4 times higher chance, due to chronic inflammation, which tells you control the inflammation, right? That's the message, that's the takeaway. But as you said, methotrexate in particular has been shown to actually lower the risk of both Alzheimer's and dementia, which is amazing. Also, TNF inhibitors like your Enbrels, et cetera, are proven associated with less Alzheimer's risk as well. So that is a great little takeaway there.
Can I jump in quickly about one thing I remember is he was really excited to mention how in like 10 years or so, he hasn't seen as much vasculitis, which is really cool to hear. And did he, I can't remember if he expressed why that was, or if they haven't figured that one out.
Because of treatments.
Because of treatments? Okay. So yeah, see, there's all these little things, the comorbidities and devastating things that happen to us are starting to be reduced because of the better treatments we're getting. It's exciting to hear.
I did not want to forget this one. A natural way of treating this. So he talked
Michael
about,
put it in the chat. He put the vagus nerve stimulation from the Cleveland Clinic. He added that to the chat, which is great.
Michael. So the vagus nerve is the longest cranial nerve in your body, and it can play a role in your health. There was a study that they showed that if this vagus nerve was stimulated, the inflammation went down, and so did the disease activity score. And that's those things where the big hands, and you're like telling them, oh, this is how I feel, and there's a disease activity, and they're pressing, and then it adds up to, you might see it DAS 28. It's like there's 28 points. So that measurement and the inflammation in being measured in your blood went down. That is a natural way of treating this. So first time I heard of it, thanks Michael for putting the link that I found earlier in there. So look that up. I thought that was something that was worth talking about. And then last but not least, the structure and the function of the brain and the way that the brain communicates changes the way you feel, and is kind of alludes to what Eileen said. He said, I treat the arthritis and it goes away, and the brain fog just doesn't. And so I think that kind of sums it up. I wish we had more time. We still didn't even get to a lot of the things that I had here on my screen. I've got artificial intelligence I haven't pulled up. I've got Sjogren syndrome. I've got a lot of stuff here that just didn't make it, that I'm just going to have to put in the comments because we are just out of time.
But there's always chance. Yeah, and there's always chance for more content creation. These facts won't always leave us. They will continue to be disseminated in other ways.
Yes, absolutely. Yeah, and I actually, as far as the vagus nerve stimulation, over the years, I actually know people that participated in the study and did the vagus nerve stimulation.
Oh, you do?
Yeah.
Same here.
Yeah. So, and there's other ways of doing simulation, wearing these helmets for periods of time and all the different things that they're learning. And again, through research, I think it's just fascinating that how they hone in on certain pieces, and it just makes such a difference in people's lives. But again, not everybody. So everybody's individualistic, and what works for me may not work for the next person. But again, all the different things that are coming up, and there's hope that something else is coming.
Very, very well said. And I did glimpse at the link before I asked Michael to share it for the Vegas how you could do it sort of on your own. And it just talked about mindfulness. So I don't know. I didn't go that into it, but it's worth looking at. So, but I do think that that is a good way to wrap this up, Deb, with just the takeaway that there's hope. I mean, there's a lot that's going on in research, and I cannot say enough. I know I sound like a broken record, but I cannot encourage you enough. If you are a person who feels that you can use this information and put it back into your healthcare journey, please sign up to go with us. We're going again to the American College of Rheumatology in November of 2023, almost said 2022, went back in time. And we do this every year for definitely EULAR and ACR, but we're going to be adding some more conferences along the line to this, but these are currently the two major ones that we report back. So we strongly encourage you because, again, as we mentioned earlier, unlike last Go With Us, even though we're going to wrap up after another watch party, so we're still going to go through and find some good clips, and that will be the last of our kind of official debrief type of sections. We're not going to stop reporting back. So you would be the first to know of things. I mean, you might miss it if we post it on social media, right? But if you're subscribed to our Go With Us, you're going to be in the know. And then we strongly, say, hey, come with us when we go to ACR next time. And then in a couple years, you're going with us and you're going with us. And guess what's going to happen? Some of these exact things that we reported today are going to be built upon because they're going to come back and they're going to report. And then it's all going to start clicking. And you're going to go, oh my gosh, I know, I saw that, and I see where it's going. And it's just, that's when for me, it all just really gets exciting. So last words from Deb.
Just, tune in. And also, I want you guys to also please consider donating to AiArthritis. I know there's going to be some other information coming out about that. I know Phaedra did in our daily updates. She had actually shared the link a few times. Part of our funding isn't for flying us to different countries to do this. So
the donations help things like this.
Yes,
right
exactly.
Now. Yes,
so that's the specific
donations to fly us to different. So I want to, right. I know that there's been some confusion about that in the past. So
not at all. Yeah.
But
it makes the difference.
The extra work, the having Michael doing an amazing job in the chat and all of that, those are things that we pay staff to do. So if you feel that we're doing a good job with this program, we certainly would appreciate donation. And so thanks for mentioning that, Deb, because we do largely operate on gifts from our community. Eileen?
Yeah, I would also highlight donate, because the work that we do is valuable and it's important, it's unique, and it's hard work. It can't be done without the right equipment, knowledge, people, experience, and whatnot. So if you're looking for an organization to donate to that is truly making a difference and funds helping patients, here you go.
Thanks, Eileen. All righty, so we are going to wrap up. Also, I keep sending you to AiArthritis.org. You could donate while you're there if you so wish, and of course would be appreciated. But also on the bottom, you can sign up for newsletters too. So if you're interested in any of the work we do, not just research, we do a lot in awareness and education and public policy and all kinds of things. So you can always sign up for that monthly newsletter as well to stay informed, and follow us on all of our social media channels at AiArthritis. And I think that is a wrap. I will be adding more things to the comments that didn't make it into this debrief because there was just too much to learn. So keep putting your questions also in the comments. This video will stay on Facebook, and you'll be able to continue the conversation. So please keep asking questions, and we will keep following up and doing our best to answer them. All right. Okay. Well, we are signing off from our 2023 for now, but like we said, the journey is not over. So we will talk to you all soon.